The aim of this article is to present a quick, simple and cost-effective technique in treatment of patella baja due to adhesions in the deep infrapatellar region. Such adhesions may be caused by multiple reasons, in example as a consequence of bone-patellar tendon bone autograft harvesting, by the Osgood-Schlatter disease. Nevertheless, of the reason, those adhesions may limit the length of functionally active part of patellar tendon and lead to patella baja with subsequent consequences. Importantly, as it can be seen, in those cases the patellar tendon length is commonly within normal limits, but due to adhesions, only the free part of the patellar tendon is functionally active. After the surgical access to the anterior part of the tibia is achieved, the patellar tendon is elevated bluntly with surgeon's finger and the restricted movement of patellar tendon is confirmed. The adhesions between the patellar ligament and bone are transected with scissors on the lateral and medial side of the tendon. Then, the patellar tendon is firmly pulled with the finger, breaking the bursal adhesions. The separation of patellar tendon from the tibia in the deep infrapatellar bursa region is confirmed. The second part of the procedure is to create and interpose the Hoffa fat pad pedunculated flap between the patellar tendon and the area of the tibia after separation. The Hoffa's fat pad is grasped with tweezers and scissors are used to gradually create a pedunculated flap of fat tissue. The size and mobility of pedunculated flap are checked every cut or two. The aim is that it is possible to interpose the flap between patellar tendon and bone in the deep infrapatellar bursa region without tension in order to avoid recurrence of adhesions. The length of the flap has to allow for full knee flexion without excessive tension. Then, the created flap is sutured to the periosteum remnants and surrounding soft tissues in the deep infrapatellar bursa region. If soft tissues are lacking or they are of poor quality, it is acceptable to suture the flap to the most distal dorsal part of patellar tendon or to use a suture anchor. The pedunculated Hoffa's fat pad flap is used in this technique instead of non-pedunculated fat graft, because the blood supply through the peduncle is believed to improve long-term results. Full range of motion is achieved. 3 years after surgery, the patient has no symptoms and full range of motion is possible. The length of functionally active part of patellar tendon increased significantly from before the procedure to the 3 years follow-up.